So today we will do the Porto Caval Anastmoses. Or Porto Caval sites. So there are total 7 sites are there where there is a communication between the portal system, venous system, and the systemic venous system. And its main applied is the portal hypertension. Now, as we know, the portal hypertension starts from the 6-meter long jejunum and ileum. So the mucosa of the jejunum ileum is made with villi for the absorption of the food, which is in the form of the liquid. So the veins, small veins, start from the villi, and all the veins unite to form the radicals of the portal vein, carrying the food plus deoxygenated blood. So blood in these venous radicals from jejunum and ileum contains very precious blood. Why it is called precious blood? Because it contains the food in the form of the molecules absorbed from the villi. So all these portal veins ultimately they unite. All these small portal radicals they unite to form the portal veins. Portal vein radicals which accompanies the branches of the superior mesenteric arteries, jejunum and the ileal branches. And these veins ultimately, from the entire 6-meter length of the jejunum ileum, they all unite to form a vein, but that is called the portal vein. So in this way, whatever food we have taken is ultimately absorbed and thrown into the portal vein. And this portal vein, so formed by these portal radicals, is called superior mesenteric vein. So it contains a very precious blood. And the absorption which has been taken place from the large intestine, the sigmoid colon, the descending colon, transverse and the ascending colon. So veins they also start from them. And these veins they also absorb the water from the large intestine. And all these veins from the large intestine, they also unite to form a vein which is called the inferior mesenteric vein. And this inferior mesenteric veins lying retroperitoneally, and it will open into a horizontal vein running behind the pancreas, which is coming from a viscera or organ from the hilum of which is the splenic vein. So splenic vein runs behind the pancreas, and this inferior mesenteric vein will open into the splenic vein. And this splenic vein runs behind the pancreas. Now receive the excess of the water absorbed from the large intestine vein. And the splenic vein then ultimately will meet with the or unite with the superior mesenteric vein. And after union, it forms a vein that is called the portal vein. And this portal vein lies behind the neck of the pancreas. Behind the neck of the pancreas. This is the head, this is the neck, this is the body of the pancreas. So portal vein is so formed behind the neck of pancreas by meeting of the splenic vein and splenic vein runs upward in the right free border of the lesser omentum, just in front of the foramen of Winslow. And here portal triad is formed. The portal vein lies posteriorly and the hepatic artery proper runs in front of it on left side. And in front of the portal vein on right side is the common bile duct. So that is the relation of the portal vein with this. So portal vein lies behind of it. On right side is the common bile duct and on left side is the hepatic artery proper. And it lies in the right free border of the lesser omentum. And ultimately this portal vein then reaches the liver into porta hepatis and divided into two veins, right and left portal veins. And they go into the largest gland of the human body, that is the liver. So into the porta hepatis. So the right portal vein will go into the right lobe of the liver and divide into numerous portal radicals, which will be also accompanied by the bile ducts, and hepatic artery will also accompany the portal vein and it will divide into arterial supply of the liver. So that is how it goes. From the porta hepatis is the area from where these three structural portal triad enters into the liver. Now inside the liver we know the histology of the liver. Whole of the precious blood of the portal system is thrown into the liver. And we know the histology of the liver. So liver cell or the hepatocytes, they are hexagonal in outline and they form the long chains of the tract with a gap between them. So these cellular pattern of the liver lobule, histology of the liver, make a small canaliculi or a gap between these hepatocytes. So this blood coming from the food we have absorbed while the portal vein is thrown into these canaliculi, they are called the hepatic sinusoids. Not sinus. It is a blood containing reservoir that is called the sinusoid, means smaller than a sinus, as we have done the superior inferior septal sinus, cavernous sinus. So this is also a sinus, but they are small, so they are called sinusoids. So from the one end of these portal veins, they surround the lobules of the liver and they go into the one of the peripheral end of these sinusoids. And these portal vein radicals, they are also accompanied by the branches of the artery at the peripheral end of the sinusoid. So both the arterial blood and the venous blood mixes in the hepatic sinusoids. There is a mixture. And the portal blood mixed with the arterial blood in the hepatic sinusoid. So whatever food you have taken in the form of the monosaccharides, small chains of the amino acid like the protein, the triglycerides, the digestion end product of the lipid metabolism. So all these wanted molecules of the carbohydrate, protein and fat, they are absorbed in the hepatocytes, which lines the hepatic sinusoids. So liver hepatocytes are the storage or the storehouse of the carbohydrate, protein and so they are deposited here, stored in the hepatocytes. And whenever we require them, they releases into the bloodstream, again goes into the blood, the other end of the sinusoid. So after the absorption of the oxygen from the arterial blood and the food from the portal blood, whatever the deoxygenated blood is left is collected on the other end of the hepatic sinusoid, and this point is called central vein. So this is the how central vein of the histology is. So whole of the rest of the deoxygenated blood is thrown into the hepatic veins, and all these central veins, they unite to form two right and one hepatic veins. And these hepatic veins opens into the inferior vena cava, which is passing through the substance of the posterior surface of the liver in a definite groove. So the inferior vena cava is sink in the substance or the surface of the liver, so that two right and one left hepatic veins, they pour their deoxygenated blood into the inferior vena cava, which goes up in the right atrium. So this whole circulation, starting from the absorption of the food from the radicals of the portal vein, and ultimately it reaches into the inferior vena cava. This system is called portal venous system of the human body, GIT. So this is how our food reaches into the liver, and from the liver it ultimately reaches into the venous blood of the heart for the distribution of the carbohydrate, fat and protein and minerals and other things to each and every corner of the body. So that is the portal system. And what is the systemic system? The caval system is, caval were taken from superior and inferior vena cava. So when we say the caval means, we are talking about the either superior or the inferior vena cava, which is the largest veins of the human body, collecting impure blood from every upper half and lower half of the body, and ultimately thrown into the right atrium. So this is the structure. So portocaval means portal veins, and the systemic vein, that is the connected to the superior and inferior vena cava. All the veins connected to the superior and inferior vena cava are throwing the blood into them, as right and left hepatic veins, they come under the caval or the systemic circulation. So that is the system. So that is the brief, what is the portal system and what is the caval system. Now, this is the normal blood flow, but there are regions through which this system becomes obstructed, and blood reaching into the liver for the storage of the foods from the intestine, villi of the jejunum, it cannot reach the inferior vena cava. It remains there. So what will be the problem? So the problem of the portocaval anastomoses or the portal vein or portal system is the portal hypertension. Portal hypertension. Portal hypertension means the blood in the portal vein got higher pressure and there is a backflow of them. So that is all. As we know, blood is not only absorbed from the jejunum and from the large intestine, blood is also absorbed in the upper part, that is from the stomach as well. We know there are certain food materials which are absorbed readily in the mucosa of the stomach. Before it reaches into the jejunum, it takes about 6 to 7 hours to reach the food into the villi. But in the stomach, it is immediate. We take the food, it is immediately thrown into the esophagus and it enters the stomach. So certain things, they are readily absorbed by the mucosa of the stomach. And the veins starting from them after the absorption, they all unite to form the left gastric vein which opens into the portal vein. So this is the normal venous drainage of it. So veins absorb the food we have taken. For example, the glucose, the water, certain medicines, even poison is absorbed from the veins, the left gastric vein, which is one of the tributary of the portal vein. So this is one. Similarly, veins from the pancreas and the duodenum, they also open. They also open into them. So they are taken from here. So they are called the portal hypertension. So now this is a normal flow of the blood going from them and entering the portal vein to the liver, from liver to the hepatic veins and ultimately to the inferior vein. This is normal blood flow. And from the superior and the inferior pancreatic or duodenal veins also. This is a normal phenomenon. In portal hypertension, what happens? There is an obstruction on the portal blood flow. And there are three sites or the three causes of portal hypertension. Number 1 is, number 2, number 3. That the pre-hepatic causes. Then hepatic causes. And post-hepatic causes. In pre-hepatic means something is wrong before the portal vein enters into the liver. Then there is some obstruction is there. Now blood is not going into the liver, it is coming back. And most common site of the pre-hepatic cause is the cancer of the head of the pancreas. Or any growth in relation to the pancreas or duodenum. So now there is an obstruction here. When the pancreas cancer is there, it will press because behind the portal vein is behind the neck. So this will be pressed, portal vein. Now blood which has to go up, now coming back. So that is the ill effect of the portal hypertension, that is pre-hepatic cause. Then comes the hepatic cause. So the pre-hepatic cause, most commonly the common area, or sometimes there is a lymph nodes around the portal veins in the right free part of the laceromentum. They are enlarged because of the C of the gallbladder, C of the cholangiocarcinoma of the common bile duct. So these lymph nodes becomes large and they will press the vein, portal vein, into the right free border of the laceromentum. Again, the blood will flow backward. It is not going into the liver. So that is the pre-hepatic cause. The cancer of the common bile duct or gallbladder or extrabiliary hepatic apparatus. Extrahepatic biliary apparatus may be problem. Then hepatic cause. Most common cause of the portal hypertension is the hepatic cause. That something is wrong in the liver. And most common wrong in the liver is the hepatitis. And the hepatitis means the walls formed by the hepatocytes These cells, they are, itis means they are red, swollen, painful and hot. So when these cells, they will enlarge or swell up, then what will happen? The sinusoid walls will be collapsed. Now no blood now enter into the sinusoid, it will go back from where it is coming. So that is the ill effect of the portal. So the reversal of the blood flow in the portal venous system. One is the hepatitis, another common reason is the cirrhosis of liver. So chronic alcoholics, they ultimately suffer from liver cirrhosis. Liver is shrunken. Its liver sinusoids, they are collapsed. Even biliary radicals, they are also, canaliculi, they are also collapsed. So now, they undergo, the cells of hepatocyte cells, they undergo fibrosis. They are permanently damaged. So this collapse of the sinusoids, now no blood can enter into them, and no, it can't go into the central vein, it cannot go into the hepatic veins, it cannot reaches the inferior vena cava. And whole of the blood flows back into the jejunum ileum, into the villi, or in the large intestine, or into the stomach, or into the pancreas, or into the duodenum. From where it is coming, it is going back flow. So that is the ill effect of the hepatic cause. Or there may be the cancer of the CA of the hepatoma of the liver. Some tumor is there in the portohepatitis, which is pressing the entry of the portal blood into the liver. So they are the hepatic cause. Then comes the post-hepatic cause. That is, something is wrong behind or beyond the liver. And most common cause is the CA of the inferior vena cava. So cancer of the inferior vena cava will press the inferior vena cava and the blood will come back. So that is called the 3 causes of the portal hypertension. Now what are the ill effects of how the patient has got the sign and symptoms of the portal hypertension? So it is just the hemodynamics. The sign and symptoms of the portal hypertension, number 1 is the ascites. And ascites lead to the distension of the abdomen. So portal hypertension patient have got the distension of the abdomen, and it is because of the ascites. What is ascites? It is the fluid collection in the greater sac or in the peritoneal cavity of the abdomen. So from where this fluid is coming? As you know, these portal radicals, they are retroperitoneal. So when there is a portal hypertension, now the blood is not going up, it is coming back. Here also it is not going up, now this blood is coming back. And this blood is coming into the radicals, it goes and reaches this. So the veins in the villi, they are filled with the blood. And this blood, when passing through the radicals, and blood flow and the pressure is too much, then the water will come out of the dilated veins. And that water is collected in the abdominal cavity. And that fluid, this is called the transudate. This transudate fluid is collected in the free and abdominal cavity, and that is called the ascites. And as the disease progresses, the amount of the fluid increases and the distension of abdomen also increases. So that is called the cause of distension of the abdomen in the portal hypertension patient. Another problem with this is the patient complaint of loss of appetite. So due to the portal hypertension, why is there loss of appetite? It is because as the blood is coming back into the villi, so villi, they are all filled with the blood all the time. And as the patient takes the food, it reaches the jejunum for the absorption, there will be no any absorption of the food. Why? Because the portal veins, which has to absorb the food, they are already filled with the blood pressure, with the blood, due to portal hypertension, the backflow. So there will be no absorption. Patient will take the food, but it is not absorbed by the villi and it goes out of the body through the anus. Body is not taking over. So that is the patient feels that it doesn't have got any appetite because veins they are already filled. All the veins of the stomach, mucosa, they are filled with the blood. Food is coming here for 3 hours to stay here, but it is not taken up by the veins of the left gastric veins. So patient feels that my stomach is full. So that will lead to the loss of appetite. And the loss of appetite ultimately lead to the loss of weight. No food is taken, a very, very little amount of food is taken by the person or the patient. So his health deteriorates with the time, and due to loss of appetite, he won't take anything, and patient comes with the loss of the weight. So that is the ill effect of the portal hypertension, that the patient complained of the distension of the abdomen, loss of appetite, and loss of the weight. So that is the symptoms of the patient. Now a physician, whenever he will check the patient, now what he will find? The signs of the portal hypertension. Whatever patient says, these are the symptoms. And whatever a doctor finds in a patient for a particular disease is called the signs of that disease. So what a person or what a doctor observe in the patients of the portal hypertension, so these are the 7 sites. 7 areas are there where ultimately the portal blood will try to go into the systemic circulation and try to reach the heart through the superior or the inferior vena cava. So that is called the 7 areas are there in the human body where there are chances that a little amount, whole of the portal blood cannot go in the portal hypertension to the heart, but some amount reaches there. So these sites, 7 sites, they are present, but they are now open to tackle with the portal hypertension, and they try to save a patient for some time. So these are called the 7 sites of portal caval anastomoses. So this can be exemplified from a city. If there is a particular city there and we are going into the city, but the main entrance of that city is blocked by some reason, then but we want to go inside the city. So what we will do? We will go the sideways and we will find some small pathways or the roads or the tracks through which we ultimately go inside the city. So these ways through which we want to go inside the city, not from the main gate but from some side ways. So there are 7 side ways from where we can go into the city, the same as the portal blood will find 7 gates or 7 sides to reach ultimately inside the heart. So that is meaning by portocaval sites or the areas. And we will discuss one by one these sites. Let us enumerate them where they are present. If we find these sites, 7 sites, like the 7 wonders of the world, the 7 sites we have to remember. These are, number 1 is the lower end of the esophagus. Then rectum. Third site is umbilicus. 4th is the bare area of liver. 5th phase is falciform ligament or ligamentum teres. 6th site for this is the posterior abdominal wall. And 7th site is the, where it is present, ligamentum venosum. So these are the 7 sites you have to remember. We will now explain one by one. What is happening in the portal hypertension to the lower end of the esophagus? We know the lower end of the esophagus is intrathoracic as well as the intra-abdominal part. The part which is intrathoracic is drained by the intercostal veins, and they form the azygos and hemiazygos system of the veins. Ultimately, this azygos vein opens into superior vena cava. This is normal. And the abdominal part of the esophagus is drained by the tributaries of the left gastric vein into portal vein and goes. But in the portal apparatus, now blood is not going here, it is going back. So it comes into the esophageal veins. And these esophageal veins, now they will communicate with the azygos venous system of the thorax, which is draining the abdominal part of the esophagus. Normally these veins, they are present, but there are no blood flow is there. Upper is upper, lower is lower. But in the portal apparatus, now large amount of the blood will reach this site. And these veins communicate with each other. Azygos venous system of the thorax and the left gastric. And these veins, so much blood want to go into the superior vena cava and ultimately heart, but it cannot accommodate this much of the blood. So these veins comes under pressure. That is the gastroesophageal veins under pressure, and they are dilated in the submucosa. And normally when we take the barium swallow study of the esophagus, normal and in the portal apparatus, what is the difference? In the normal, the mucosal folds of the lower end of the esophagus, they are vertical. Why vertical? Because underlying veins, they are vertical. They are the left gastric veins, and these are the azygos veins of the thorax. They are normally, they are lying end to end like this, but they are not communicating. But in the portal apparatus, what happens? A large amount of the blood is gushing into it. And the mucosa covering the inside of the esophagus, now when we see it, it becomes tortuous. Why tortuous? Because veins into them, they are dilated by the portal blood, which try to go into the superior vena cava. So this communication occurs between these veins. And these veins, they are dilated because of the high blood flow of the portal blood into the esophageal veins. And because of the more blood, so the straight veins, they become dilated and become tortuous. So they are called the varicose veins of the esophagus, or what is the name? It is called esophageal varices. Esophageal varices. So varices are there. And they are progressively, they dilate with the passage of the time. And one day will come when the mucosa covering these thin walled dilated esophageal veins, they will rupture with the stretching of the mucosa over them. On that particular day, patient will got the vomiting of blood, that is called hematemesis. So vomiting of blood is hematemesis comes. And patient rushes to a doctor that I am having the vomiting of the blood. And when we do the endoscopy of the esophagus, what we find? Esophageal varices, dilated veins. Or when we do the barium swallow study, what we find? The vertical white columns of the barium normally coming. Now they are coming, they are not vertical, but they are tortuous. The tortuous of the vertical veins in the lower end of the esophagus is the significance of the portal hypertension. That is the one diagnosis, the cause of hematemesis. Now, number second is what is happening at the rectum. As we know, rectum is continuous with the 38 mm of the anal canal. And this anal canal is having three veins. Superior rectal veins, which are mainly 3, 7 and 11 o'clock position, because they are the first tributaries of this inferior mesenteric vein, the superior rectal veins. The middle rectal veins and inferior rectal veins. The middle rectal vein is the direct vein, goes to the internal iliac vein. And the inferior rectal veins is the one of the branch of the pudendal vein. Ultimately go to the internal iliac vein. So this is the normal venous return. This is systemic, this is the portal radical. Now because of the backflow, now blood is coming into the superior mesenteric rectal veins, they are dilated. And these dilated veins in the lower part of the rectum, above the pectinate line of the upper 15 mm of the mucus. So this is the pectinate line found by the lower end of the anal walls. So veins below these vertical folds like the esophagus. Why these vertical folds of the anal canal here in the upper 15 mm above the pectinate line is because of the underlying straight radicals of 3, 7 and 11 positions of the superior rectal veins. Now blood from the middle rectal vein, superior rectal vein, it tried to go into the middle rectal vein. So, but whole of the blood cannot go because these veins are very thin. We have not seen such blood flow from the superior rectal vein. So these veins, like esophageal, they are also dilated. But these dilated veins, they are in the particular areas. Not whole of the veins, but some veins. So these dilated localized veins of the mucosa of the anal canal is called the piles, or what is called the hemorrhoids. They are filled with the venous blood. Hemorrhoids or piles is the cause of the portal hypertension of these radicals of superior rectal veins. Like esophageal varices, when these becomes large and dilated, the mucosa covering them will be thin and will be apart and will be broken, and patient will get the loss of blood. Bleeding will be there through this, but this bleeding is painless bleeding. So painless bleeding per rectum is the cause of the most common cause is the piles of the hemorrhoid. So that is why the hemorrhoids are there in the patients of portal hypertension. Patient becomes more weak, already weight loss is there, because of the loss of blood he becomes more weaker and the death is. So that is the rectum. Then umbilicus. As you know, umbilicus is the area which is connected in the fetal life with the mother, and there are two hepatic umbilical veins and two umbilical arteries connecting the mother with the baby. But immediately before the birth of the baby, what happens? The left umbilical vein is left, right is disappear. And this left hepatic vein, which is obliterated inside the abdominal cavity, ultimately goes into the liver. Through the lower end of the falciform ligament, that is from the ligamentum teres. So this is already obliterated and goes into the portal hepatis. Now because of the portal hypertension, now this obliterated vein also opens. And blood from the portal vein, which is going into the liver, will get access to this blood, and this blood is coming up to the umbilicus. And around the umbilicus there are already veins are present. Above the umbilicus and below the umbilicus there are systemic veins. This is the watershed zone or the watershed line of the umbilicus. We know the blood flow goes like this, normally like this. So now blood is coming from the portal, blood is coming via the obliterated umbilical vein in the ligamentum teres or the falciform ligaments, and it will go into these veins. And now the blood will go, the direction of the blood in the portal hypertension is like this. It will go in the centripetal rather than centrifugal. So these veins ultimately, because of the large amount of the blood try to go, they also undergo the varicosity. They become tortuous and dilated. So these dilated veins around the umbilicus, whose blood flow is now reversed, it looks like the jellyfish-like appearance. And because of the jellyfish-like appearance of the dilated veins around the umbilicus, we evolved the word, the condition, this sign is called caput medusae. Caput medusae is the name given. So caput medusae is nothing but these are the dilated veins going away from the umbilicus. It looks like the jellyfish-like appearance. That is called the medusae, means jellyfish-like. Caput medusae is the name. So that is the another sign. Whenever we remove the clothes of the patient lying on the operation on the examination table, and we lift the clothes, what we see? This picture of the abdomen. The standard abdomen along with the caput medusae is this sign we find to strengthen our claim of portal hypertension. Now comes the bare area of the liver. As we know, the liver is connected to the diaphragm, and the bare area of the liver is directly in contact with the diaphragm. And the bare area, there is no any peritoneum between the diaphragm and as you know, the veins of the diaphragm, they go into the aziagous venous system of the thorax, go to the superior vena cava. And the veins of the liver, they are the portal veins, they go into the inferior vena cava through the hepatic veins. But now in the portal hypertension, what happens? Now blood will go into the hepatic veins, and they are not going into the inferior vena cava, they are coming back. And these veins cannot go into the inferior vena cava, so blood will go ultimately to the bare area of the liver, where there is no any peritoneum is covering. This is the peritoneum on the liver and the under surface of the diaphragm. And in between, this is the bare area. So the veins of the diaphragm, which is going into the aziagous venous system of the thorax, above into the thorax. So these portal veins, now they communicate with these veins of the diaphragm. And now blood will try to go into the superior vena cava through these. So this is called the, what is happening at the bare area of the liver. The blood try to gush to the phrenic veins. Then come the falciform ligament. As we know, falciform ligament is attached to the liver plus anterior abdominal wall. So this anterior abdominal wall with the umbilicus and the liver here. This sickle-shaped falciform ligament, the veins of the anterior abdominal wall, they now connect with the liver, the portal vein, and blood is coming back into the, so veins in the two folds of the falciform ligament, they are dilated because of the backflow, and these dilated umbilical veins, ultimately these veins in the falciform ligament reaches the umbilicus, and in the umbilicus they communicate with the para-umbilical veins, and this is also the cause of the caput medusae, additional to that. So that is the, what is the falciform ligament is doing. Then the posterior abdominal wall. In the posterior abdominal wall, what happens? The jejunum ileum lying retroperitoneally, inferior mesenteric vein lies retroperitoneally, superior mesenteric veins and this portal radical, they are all retroperitoneal structures. Beside these veins connected to the GIT, another veins which are connected to them and going into the inferior vena cava in the posterior abdominal wall are the lumbar veins and lumbar aziagous veins system. So these lumbar aziagous system is the systemic, and these superior and inferior mesenteric radicals which are also present with them, Now they will communicate with them. So there is a communication between the venous system in the posterior abdominal wall, and this portal blood will try to go from the colic veins, for example, into the lumbar veins, and then they try to go into the inferior vena cava and they try to reach into the heart. So these channels, they are also get open. So these veins, they are also dilated, and some blood, amount of the blood will reach the heart through this connection into the posterior abdominal wall. Then last is the ligament of venosum. So ligament of venosum is the remnant of the sinus venosus. So in the intrauterine life, what happens? The left portal vein is connected to the inferior vena cava through a vein that is called the ductus venosus. It remains obliterated after the birth of the baby, but now in the portal hypertension, now the blood, this vein get open, and the portal blood coming into the liver, it will try to go through this small vein, tiny vein into the inferior vena cava. So it cannot withstand a large pressure of the vein. So some amount of the blood also flows through this ligament of venosum, and it will try to reach the inferior vena cava. So this channel also open. So this is how we explain the 7 sites of the portosystemic or portocaval anastomosis in the detail. Thank you.